Hello again. Acute pancreatitis is something you can expect to run into relatively frequently, especially if you're working down in the ED. So this is definitely something to know. So just some anatomy here. The pancreas is intimately involved with the biliary system, in as much as our biliary system from the liver and the gallbladder join up with the pancreatic duct, which isn't carrying bile, but carrying pancreatic secretions, pancreatic fluid, which consists of enzymes that are necessary for digestion. And it meets up with the common biliary duct just proximal to where it goes into the duodenum. And after it joins with the common biliary duct, it becomes the ampulla of Vater. Now that's going to be important for something when we talk about acute pancreatitis. It is possible for a stone to block the pancreatic duct, and that can cause pancreatitis. So there are some interactions between the biliary system, the liver, and the pancreas. Alright, so here's a vignette. This is a real vignette. So actually a patient that I saw relatively recently. So a 47-year-old man presents to the ED accompanied with his wife and son, complaining of subcostal relentless upper abdominal pain, which is focused on the midline and radiates to the back. The pain started about 4 hours ago when he woke up. He has had 2 episodes of non-bloody emesis since the pain started and is presently nauseous. The pain is made worse by laying flat. Blood pressure is 160 over 110, heart rate 105, respirations 20, temperature 101.2, saturation 88%. He smokes tobacco and consumes alcohol heavily, about 1.5 liters of vodka per day. His last drink was about 10 hours ago. He has no complaints. He denies any changes in bowel movements. He has no surgical history. His past medical history is significant for mild hypertension, which is controlled on lisinopril hydrochlorothiazide, and major depressive disorder, which is controlled on sertraline. Physical exam reveals an obese Caucasian male with exquisite upper abdominal tenderness with guarding, mild distension, and decreased bowel sounds. Lungs are clear to auscultation. There's tachycardia but normal rhythm, and there is no ecchymosis. So you can probably imagine what the diagnosis is based on what this lecture is about. But what are you going to go about doing after this point? You're certainly going to order labs. So your initial diagnostic workup is going to include a CBC, a CMP, which a CMP, if you're not familiar with that designation, is just a basic metabolic panel along with your liver function tests. Amylase, lipase, we want an EKG as well as a chest x-ray and an abdominal x-ray, and you could probably add on to that an abdominal ultrasound. So the results from that, I'll just tell you that any acute pain in the abdomen, CBC, CMP, amylase, and EKG, and probably an abdominal or chest x-ray are going to be your minimum initial diagnostic workup. Okay, so what's our results from this? We have a CBC showing a white count of 13.2 with left shift. So I gave you your reference range down here. You'll be given that on the test. The CMP showed an ALT of 155 and an AST of 490, glucose 300, amylase of 520, lipase 255, EKG shows sinus tachycardia, and the chest x-ray and abdominal x-ray are unremarkable. So with that, we can make a pretty good diagnosis here. I could just say that the abdominal ultrasound was also didn't show any stones, just say. So the diagnosis here, most likely, as you can imagine, is going to be acute pancreatitis. The diagnosis for acute pancreatitis can be made clinically, but we do get imaging just because it helps us to see if there's any complications. So what gives us hints that this is pancreatitis? Well, first of all, This is upper abdominal pain that radiates to the back. And there's two things that you should be keeping in mind when you have a patient with upper abdominal pain radiating to the back, and that's going to be acute pancreatitis and also a ruptured abdominal aortic aneurysm. We don't think this is a patient with a ruptured abdominal aortic aneurysm because he's stable. Also that he has had episodes of vomiting. The pain has been going on for 4 hours. And also the history of alcohol consumption, and then also these labs. But we do get the imaging, the chest x-ray, abdominal x-ray, that will help us to differentiate that out. We could even get a CT if we were really concerned if the patient was particularly unstable. But more than likely this is due to acute pancreatitis. So the upper abdominal pain points us to that. The non-bloody emesis, we want to, there is emesis, we want to know if it's bloody or not, because you can have bloody emesis and that would not be consistent with acute pancreatitis. The alcohol consumption is most consistent with this diagnosis. Patients with acute pancreatitis, most of the time, in the U.S. at least, will have a history of extensive alcohol consumption. All right, so your CMP gives you an ALT and an AST, which are both elevated. And if you look at, this is really important for clinical purposes. When you look at your ALT and AST, sure, they're elevated, but your ALT is usually more than your AST. And if your AST is ever more than your ALT, and they're elevated, so you have elevated ALT and AST, but your AST is more rather than your ALT being more, it's likely that these liver enzymes are elevated because of alcohol consumption. So this liver profile panel shows that this is liver dysfunction due to alcohol consumption. And this doesn't necessarily have to be due to the pancreatitis. You can have elevated liver enzymes just due to excessive alcohol consumption. The amylase and the lipase, however, are due to the pancreatitis. So this is reflective of pancreatitis. And what we look for lab-wise is that you have an amylase and a lipase that's 3 times the upper limit of normal. So the upper limit of normal for amylase is 110. So 520 is way more than that. And the upper limit of normal for lipase is going to be 180. 3 times the upper limit of normal would be 180. So it's more than that. So 3 times the upper limit of normal. If it's beyond that, the likely diagnosis is acute pancreatitis. And then the EKG showed sinus tachycardia, and chest x-ray and abdominal x-ray were unremarkable, as they would be. So this is just your differential. These were kind of the things that when you order up these labs that you should kind of be thinking. It doesn't necessarily mean that we're really concerned about them, because remember, you're going to keep in mind your history and your physical, but when you're thinking of acute epigastric pain, these are some of the things that you would keep in mind. Of course, this patient with heavy alcohol consumption, sudden onset of acute epigastric pain, and the fact that it's been going on for 4, 5, 6 hours, acute pancreatitis is more likely. Okay, so there are 3 kinds of acute pancreatitis. There's acute edematous pancreatitis, which is more of your, I hate to use this term, but garden variety pancreatitis. This is the most common kind of pancreatitis. This is more uncomplicated pancreatitis. So yes, there's inflammation, but that inflammation is edema. There's acute suppurative pancreatitis, and this is where you have the development of abscesses. So this is not just fluid inflammation, this is bacterial infected inflammation. And then there's acute hemorrhagic pancreatitis, and this is the most severe form of pancreatitis, acute pancreatitis, and this is often deadly. I think it's around 50% or so are deadly. And this is why we check for ecchymosis. So when you're doing your physical exam, you're looking at, I didn't put pictures in of this, but you're looking at two parts of the body. You're going to be looking at the patient's flank, so right by where their kidneys would be, and then you're going to look around their umbilicus. And if there's ecchymosis there, we are very, very concerned for hemorrhagic pancreatitis when it's in the setting of pancreatitis. And in that case, we're going to do a CT right away. Okay, so acute pancreatitis. Gallstones and alcohol binging are behind approximately 80% of acute pancreatitis cases. I would say, though, that alcohol binging is probably more frequent, at least to see in the ED. Just sort of a pearl to remember, if the patient has not been drinking alcohol, then you can, and the pain came on after a meal, it's likely due to gallstones. But if the patient has a history of alcohol consumption, it's probably due to the alcohol consumption. All right, other possible causes can be iatrogenic. So we think of that during instrumentation when we're doing an ERCP for any other purpose. You can do an ERCP to visualize the pancreatic ducts, but the contrast material can be irritating to the pancreas. Also, if you do the ERCP wrong and you get the entire tool into the pancreatic duct, you can really do some damage that way too. So it can be due to a correctly done ERCP or to an incorrectly done ERCP. It can also be secondary to other disorders, or it can be idiopathic. Some of the other disorders that can cause acute pancreatitis are familial hypertriglyceridemia, cystic fibrosis, and cystic fibrosis is also a cause of chronic pancreatitis. Remember, with cystic fibrosis, you have an increased viscosity of secretions, and that's really what's behind acute pancreatitis with the alcohol consumption as well. Autoimmune pancreatitis, this is associated. This can be associated with other autoimmune disorders, or you can just have flat-out autoimmune pancreatitis. It can also be associated with direct blunt trauma to the abdomen, and then anatomic abnormalities of the pancreas. So the symptom is generally going to present as sudden pain. It's upper abdominal. Usually it's subcostal, so the patient will often describe it as just like right below the rib cage. Usually it's going to be described in the middle, but it might be described more on one side than the other, so that can make things a little bit more confusing. As far as radiation, it's usually going to radiate to the back. Also, it's going to radiate to the shoulder, because you may have some diaphragmatic irritation, and that would then refer to the shoulder. This is usually a constant pain. It's not colicky, but the patient can usually find a position to make it feel a little better. Usually that doubled over, sitting up in that doubled over position might make it feel a little better, maybe not, but that's usually the position that most patients prefer. The position that patients do not want to be in, though, is laying flat. And if these patients get brought in by the ambulance, they're probably laying flat and they're going to want to be sitting up. So that may be something to note. Nausea and vomiting are extremely common. Usually the patient will already have had a history of nausea and vomiting. Invariably, it worsens with eating, and that's one of the most important things to remember. This can either be brought on by eating, or if the patient has the pancreatitis already and then they try and eat something, it gets worse. And their pain gets worse, and usually they'll vomit whatever they've eaten up. So physical exam, the vital stability can vary. Obviously, if you have a patient who presents in shock, your management is going to be a little different. You're going to not be jumping quickly to doing your labs. You're going to be stabilizing the patient volumetrically. However, even though the patient's vitals can vary, and in the patient in this vignette we had a relatively stable patient, as most are, all patients with acute pancreatitis are, by definition, dehydrated. Physical exam will reveal the symptoms of abdominal pain. They're going to be tender. There may be guarding and distension, and you'll also, of course, like I mentioned, you'll want to check the umbilicus and the flank for ecchymoses, as this indicates a more severe disease. That would be hemorrhagic pancreatitis, and that is going to require a trip to the CT room right away, and these patients will need to be monitored very closely in the ICU. Once the patient is stabilized, they can be sent off for admission. But like I mentioned, if it's a complicated patient, if they came in with shock, if they've had more of a complicated case where you've needed to give them fluids, if they've got ecchymoses, you'll want to get them off for an early CT. The reason we don't do CT right away on patients with acute pancreatitis, on everybody with acute pancreatitis, is because usually when the pancreatitis starts out, there's not a lot of CT changes. So imaging isn't really going to be tremendously helpful. Primarily what we do imaging for is to look to see if there are any stones blocking the pancreatic duct. So for diagnosis, acute pancreatitis is often suspected and diagnosed on clinical and laboratory grounds. Remember your typical presentation as well as your labs. Most importantly, an amylase and lipase that are 3 times the upper limit of normal. You'll probably also see elevated liver function tests, and that's either that's usually secondary to the fact that the patient is already an alcoholic, or the fact that they have a stone. Abdominal ultrasound would be your best initial diagnostic step, and the reason we're doing that is to rule out the presence of stones. So if you do have a stone, abdominal ultrasound will catch that very well. You may also see some abnormalities of the pancreatic mucosa, but we're not necessarily looking for that. With the abdominal ultrasound, what we're looking for is the stone. Because if it is a stone, we're going to manage it a little bit differently. So if it is a stone that's blocking the pancreatic duct, we call that biliary pancreatitis. It's still acute pancreatitis. It's just secondary to a gallstone blocking the pancreatic duct. And this is something that you should suspect in the non-alcoholic acute pancreatitis patient, especially the patient who suddenly got their episode after a big meal and they haven't had any history of consumption of alcohol. So the treatment, of course, fluid resuscitation is important in early management. It's absolutely critical if the patient is unstable. All patients should be admitted to the floor or ICU. More and more of these patients are being admitted to the ICU just because we're recognizing some of the complications that come out of this. Definitely if they have an unstable course, though, they're going to be sent to the ICU. Continuous IV fluids are going to be necessary along with glucose just because we're going to have these patients on NPO. We want to have these patients on NPO around 48 hours, and the reason we're doing this is we're giving their pancreas some rest. And by giving their pancreas some rest, remember what the pancreas secretes. It secretes things that help us digest. So if you're not eating anything, the pancreas can slow down a little bit and heal. And by allowing the pancreas to rest, that edema, infection, whatever is there, can start to resolve. You can also do NG suction. That's not necessary, though. Serial labs should be ordered just to monitor their amylase and lipase. Their saturation should be monitored. And then after about 48 to 72 hours, around when you're going to start advancing their feeds, you should get a CT. And at this point, you're checking for complications. You're checking for any bleeding, any necrosis, or any pseudocyst that might form. That's one of the complications of acute pancreatitis. Also can give them opioid analgesics to help with the pain. If the patient's severely ill, especially the patients who come in hemodynamically unstable, you should consider placing a Swan-Ganz catheter just so you get some better monitoring of their hemodynamic status. Okay, now I talk about this in the medical section where I go over pancreatitis, which kind of talk about the same thing, but Ransomes criteria is really useful to have on hand, especially when we're considering whether we want to send the patient to the floor or to the ICU. So what you should have memorized for sure is the admission Ransomes criteria, but also I would try to get these 48 hours into mind as well, because how the patient comes in on admission is going to determine whether you send them to the floor or to the ICU. So for admission, we use this mnemonic WALS. It's WALS for Chubb, but WALS is for admission. So W stands for white count if it's greater than 16. So this patient was not greater than 16. That would be 1 point. Age greater than 55. This patient was not greater than 55. LFT greater than 250. I don't remember. So you're looking at your AST. I don't remember what this patient was. I think they were greater than 250. So that'd be 1 point there. An LDH greater than 350. That would be on your CMP, but I didn't note that on here. So, but anyway, these are the things that you're measuring, and then glucose greater than 200. So white count, age, AST, which is mnemonically on your LFT, liver function test, LDH, and sugar, which would be your glucose. And these are all 1 point apiece, and then you can correspond that down here to whether severe pancreatitis is likely or unlikely, and that's kind of how you determine whether or not you want to admit them to the ICU, but just use your clinical judgment. And then the after 48 hours, your fluid sequestration, if it's more than 6 liters, that's a point. Oxygen saturation less than 60 millimeters of mercury. Calcium less than 8. Hematocrit down more than 10%. BUN more than 5 after appropriate hydration, and a base deficit of more than 4. I don't expect that you're going to have to memorize this for the USMLE, but it's good 99th percentile stuff if you do. This is more peripheral material. But you will, for sure, in clinical practice, be following Ransomes criteria. It's just when you're in clinical practice, most of the time you're going to be putting this into a calculator or have this written down somewhere. But it is good to know, especially good to know what you're kind of following, because these are all things that are important in prognosticating how the patient is going to do. If they have a more inflammatory disease, that may mean there's more necrosis. If they've got a decreasing hematocrit, that may show that there's hemorrhage, and so forth. All right, what are the complications? Well, biliary pancreatitis is, of course, a complication. It may be a presentation, that is where a stone is found on the abdominal ultrasound. This is just a different kind of acute pancreatitis, a different reason. The treatment is the same as usual, and usually these patients follow pretty uncomplicated cases. But prior to discharge, you're going to want to do a laparoscopic cholecystectomy. You want to make sure the patient is resolved. Then you can go ahead and send them off for cholecystectomy. Patients with acute hemorrhagic pancreatitis, remember they tend to have those ecchymoses, flank ecchymosis or umbilical ecchymosis. Oh, by the way, I just wanted to point out, because I didn't put pictures on here, I did want to remind you the flank ecchymosis is often called Turner's sign. So turn over and show me your Turner's sign. It's on the back. And then the periumbilical ecchymosis is called Cullen's sign. So you may hear it referred to as that. So acute hemorrhagic pancreatitis, they tend to have those ecchymoses. They present sicker. They're usually less stable. Their labs will also show a low hematocrit, and it will be stubbornly low even on replacement. And then they'll also have a low calcium despite adding on calcium to their fluids. They also may show a low oxygen saturation. So all of this, remember, that we were looking for in this whole Walspo-Chubb thing, a lot of these are complications of hemorrhagic pancreatitis. So they also can have metabolic acidosis. That's usually due to the low oxygen. And then on CT, you may see multiple abscesses. Treatment is as usual, and then drain abscesses as they appear and get serial CTs. You may want to add on, you probably want to add on IV antibiotics for these patients as well. IV broad-spectrum antibiotics, some physicians just give them to all patients with acute pancreatitis. However, there's no proof that that actually is helpful. More so, you'll want to do that for the complicated cases, so acute hemorrhagic and acute suppurative pancreatitis, and you'll do broad spectrum. So I would use carbapenems. So acute suppurative pancreatitis, I already talked about this. Sort of, this is where you got necrosis and infection. But often how this shows up is when a patient didn't get a CT while they were hospitalized for pancreatitis, and now they come back and they've got an abscess. So the way you may see this presented on a test question is that they were just in 7 or 8 days ago for pancreatitis. They were discharged, and now there's persistent fever, elevated white count, and upper abdominal pain. And then you'll want to get a CT on those patients. So if they've been admitted before for pancreatitis very, very recently, like within the last 2 weeks, you'll want to get a CT because usually an abscess is the cause. So the treatment here, of course, when you have an abscess, you need to drain it, and then these patients will need to be on IV broad-spectrum antibiotics because they have an infection. Pancreatic pseudocyst is another complication. This can be a complication of acute pancreatitis or from chronic pancreatitis, and this is generally described as a vague sensation of upper abdominal fullness or discomfort. Usually this is several weeks after pancreatitis. You can start out by trying to diagnose this on abdominal ultrasound, but CT will be a much better, more accurate test. And the treatment for this is percutaneous drainage. However, the timing on that is going to be at the surgeon's discretion because generally they want to wait for the pseudocyst to quote-unquote mature so that it's easier to repair. And then, of course, any general medical problems can come up during acute pancreatitis. Remember, this is an acute inflammation, and so you can develop sepsis. You can develop acute respiratory distress syndrome. This is something that you need to be careful for in older adults because if you hydrate them too much, they can white out their lungs, and then you have another problem on your hands. And then also remember that a lot of the patients you have with acute pancreatitis are alcoholics, and when they are put into the hospital, they are assumingly they're not drinking. So you need to remember that these patients are going to be in alcohol withdrawal, and so you'll want to have them on scheduled benzodiazepines to keep them out of delirium tremens. And if you have any questions, feel free to let me know.